Hi, my name is Octavia Pickett-Blakely. I'm a board-certified gastroenterologist, a hepatologist, and I have a subspecialty practice in clinical nutrition. I'm here to talk to you today about the gastrointestinal and liver complications of obesity. So let's start at the top of the gastrointestinal tract with GERD. Gastroesophageal reflux, or GERD, was one of the earliest GI conditions to be associated with obesity. It was recognized with rising rates of obesity and also rising rates of esophageal adenocarcinoma. In states of obesity, there's increased adiposity and increased visceral fat that results in a variety of mechanical effects, including the disruption of the GE junction, which leads to a hiatal hernia. There are also transient relaxations of the lower esophageal sphincter and increased gastric pressure, which leads to esophageal reflux. Abdominal adipose tissue also is associated with an increase in circulating pro-inflammatory cytokines, which have been linked to inflammatory processes like erosive esophagitis, Barrett's esophagus, and esophageal adenocarcinoma. Obesity, and specifically abdominal adiposity, has been also linked to inflammatory bowel diseases such as Crohn's disease and ulcerative colitis. Recent studies have linked visceral adiposity or abdominal fat to lower rates of clinical and endoscopic remission in patients who are being initiated on biologic therapy, as well as an increased time to flare in patients with inflammatory bowel disease. When you think about malignancies, colon cancer has a strong association with obesity. As you know, colon cancer is the third leading cause of cancer death in the U.S. and has been strongly associated with visceral adiposity. We do see a differential effect in colon cancer with respect to gender, with a greater effect being seen in males versus females. But nonetheless, we know that obesity is associated with the rising rates of colorectal cancer. There are certain lifestyle and behavioral aspects that are associated with both colon cancer and obesity, including low fiber diets and diets that are high in ultra processed and processed foods. And lastly, metabolic disease associated liver disease has a strong dose response associated with body weight. There is a specific increase in metabolic disease associated liver disease, starting at a BMI of around 23. MASH is the earliest part on the continuum of liver disease that can progress to MASH, steatohepatitis, cirrhosis, and in some instances, hepatocellular carcinoma. MASH is predicted to be the most common indication for transplant in the United States and has significant medical complications. Understanding the association between excess body weight and gastrointestinal liver complications is important because we do have data also that suggests that weight loss can actually improve these outcomes. For example, a reduction in reflux symptoms has been associated with weight loss. Weight loss surgery has been associated with reduced reflux symptoms. Weight loss surgery has also been associated with a reduction of obesity-related cancers, and we know that weight loss, whether it be from lifestyle modifications, anti-obesity medications, bariatric endoscopic procedures, or bariatric surgery, has been associated with a reduction in hepatic steatosis and progression to fibrosis. So with that, I hope you have a better sense of the effect that obesity has on gastrointestinal and liver health. And this will enable you and empower you in your practice to be proactive about treating obesity for your patients and preventing gastrointestinal and hepatobiliary complications.